Hello, my dear students. I am Dr. Reham Farahaty, Professor of Clinical Pathology. Today, I will talk about the appropriate laboratory tests needed for evaluation of hepatic disease. We will start our lecture by this case that will give us an introduction about the liver function tests. A male patient aged 45 years with mild weight loss and nausea. He later developed jaundice and an enlarged liver with the following laboratory results. There is elevated total serum bilirubin and elevated conjugated or direct bilirubin. The direct bilirubin or the conjugated bilirubin represent 50% of the total bilirubin. The alkaline phosphatase is mildly elevated. The aspartate transaminase is significantly elevated, and the ALT is moderately elevated, so the AST over ALT ratio is over 2, and the albumin is decreased, while the gamma-glutamyl transferase showed moderate elevation. The key in this case is the AST over ALT ratio and the elevated gamma-glutamyl transferase in addition to the elevated serum bilirubin and conjugated bilirubin. A liver panel is a group of tests that are performed together in order to detect the hepatic dysfunction, assess the severity of the liver injury, monitor the course of liver disease, and the response to the treatment. Variety of diseases and infections can cause acute or chronic damage to the liver, causing either inflammation in the form of hepatitis, cirrhosis, or bile duct obstruction, liver tumor, and liver dysfunction. Also, alcohol, drugs, some herbal supplements, and toxin can also pose a threat to the liver. First, we will start with tests that will assess the liver injury. First is the aminotransferases, the enzymes that will transfer amino group from one amino acid to another amino acid. They are alanine aminotransferases, abbreviated as ALT, which is a specific enzyme for the liver injury, and aspartate aminotransferase, abbreviated as AST. They leak from the damaged cell, thus these enzymes are sensitive indicator of liver injury. As regard the level of elevation, if it is markedly high value or highly elevated, this indicate acute hepatocellular injury. This usually occur in acute viral hepatitis, in toxins or drug-induced hepatitis, in ischemia or hypoxemia. Serial measurement better reflect the severity and the prognosis than does a single measurement. A fall to normal indicate recovery unless accompanied by an increase in the bilirubin and in the prothrombin time. For example, this is what occurs in the course of the hepatitis A. There is an increase in the transaminases in the pre-ecteric phase, and then they start to decrease at the beginning of the ecteric phase. The modest elevation or the moderate elevation in the chronic liver disorder occur in chronic hepatitis and in biliary obstruction. In most liver disorders, the ratio of AST to ALT is less than 1. However, in alcohol-related liver disease, the ratio is characteristically over 2. The second enzyme that assesses the liver injury, but it is not included in the routine liver function test, is the lactate dehydrogenase. It is present in many other tissues, and it is insensitive and non-specific for hepatocellular injury. It is typically elevated in ischemic hypoxic hepatitis and cancers. The second group of tests is the test that assess cholestasis or obstruction. First is the bilirubin. It is produced from the breakdown of the heme moiety of hemoglobin in the senescent red blood cells. It is divided into unconjugated or free bilirubin that is insoluble in water and thus cannot be excreted in urine. The second is the conjugated bilirubin. It is excreted through the biliary tract into the duodenum, where it is metabolized into urobilinogen, some of which are reabsorbed and resecreted into the bile, then into the orange color urobilin. Total bilirubin must exceed 2.5 mg per deciliter to produce clinical jaundice, which is a yellowish discoloration of the skin. Serum bilirubin level above 4 mg per deciliter suggests poor prognosis in the setting of acetaminophen poisoning. As we said in the start of our lecture, that the liver function test aiming to assess the prognosis of the liver disease. So the bilirubin is a marker that assesses the prognosis of the liver disease. As regard relation between jaundice and liver and viral hepatitis, jaundice occur in 70% of hepatitis A virus, in lesser percent, in 35% in acute hepatitis B virus, and in 25% in HCV virus. Normally, total bilirubin is mostly unconjugated with values of less than 1.2 mg per deciliter. Types of jaundice or hyperbilirubinemia were divided into unconjugated hyperbilirubinemia, where the indirect bilirubin fraction constitute more than 85%. It reflects increased bilirubin production, as in hemolysis, or defective liver uptake or conjugation, as in Gilbert syndrome. The second type of hyperbilirubinemia is the conjugated hyperbilirubinemia, where the direct bilirubin fraction constitutes more than 50%. It results from decreased bile formation or excretion, what is called cholestasis. The second cholestatic marker is alkaline phosphatase. An increase in the level of this hepatocyte enzyme suggests cholestasis. It is usually elevated above 3 times the upper limit of normal. Elevation of alkaline phosphatase is not specific because it has a widespread extrahepatic distribution. It is present in the placenta, small intestine, kidney, and particularly in the bone. The isolated elevation means in the absence of any apparent liver or biliary disorder also occur in the following condition. In some cancers without apparent liver involvement, after ingestion of fatty meals, in pregnant female, in children and adolescents, also in chronic renal failure, and in Paget disease. 5-nucleotidase increases in cholestasis and in biliary obstruction but are more specific than alkaline phosphatase. Gamma-glutamyl transpeptidase, this enzyme increases in hepatobiliary dysfunction, especially cholestasis. However, alcohol and certain drugs can cause marked increase in gamma-glutamyl transpeptidase. So we can conclude that levels of gamma-glutamyl transpeptidase or 5-nucleotidase, which are more specific to the liver, can differentiate hepatic from extrahepatic sources of elevated alkaline phosphatase. Another classification of jaundice based on the mechanism of the raised bilirubin divide the jaundice into prehepatic or hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. Apart from the type of the serum bilirubin increased, which is mainly unconjugated bilirubin in the prehepatic jaundice, there is also other differentiating point between the different type of jaundice. For example, urine bilirubin, which is absent in the prehepatic or hemolytic jaundice, and urine urobilinogen, which is decreased or absent or in obstructive jaundice. Prothrombin time, which is usually prolonged in the hepatocellular and obstructive jaundice, and it is usually normalized after the addition of vitamin K in obstructive jaundice. Additional feature of hemolysis on the blood smear, such as reticulocytosis, low hemoglobin, or low haptoglobin, is indicating the prehepatic or hemolytic jaundice. Isolated hyperbilirubinemia. What is the meaning of isolated hyperbilirubinemia? It means in absence of any associating altered liver parameter. It could be unconjugated or conjugated. The unconjugated in the form of increased bilirubin production, as in hemolysis or blood transfusion, decreased hepatic uptake, as in Gilbert syndrome, or due to drug intake such as rifampicin, decreased conjugation also, as in Gilbert syndrome or Crigler-Najjar syndrome, physiological jaundice of the newborn. As regard the conjugated isolated hyperbilirubinemia occur in Dobbin-Johnson syndrome and Rotor syndrome. The third group of tests are the tests that assess the hepatic synthetic capacity. Prothrombin time, it may expressed in time presented in second or peripherally as a ratio of the patient measured prothrombin time in relation to the control value. The INR is more accurate than the prothrombin time for monitoring anticoagulation. The prothrombin time, or INR, is a valuable measure of the liver ability to synthesize the fibrinogen and the vitamin K dependent clotting factor. The changes can occur rapidly because some of the involved clotting factors have short biologic half-life. Abnormalities indicate severe hepatocellular dysfunction as in acute toxic or ischemic liver disorders. In chronic liver disorders, an increasing prothrombin or INR indicate the progression to liver failure. Other causes for prolonged prothrombin time or abnormal international normalization ratio occur due to coagulation disorder such as a consumption coagulopathy or vitamin K deficiency. Serum proteins also assess the synthetic capacity of the liver. The hepatocytes synthesize most serum proteins, including alpha and beta globulins, albumin, and most clotting factor except factor VIII, proteins that aid in the diagnosis of the specific disorder, in the form of alpha-1 antitrypsin, which is absent or decreased in alpha-1 antitrypsin deficiency, ceruloplasmin, which is reduced in the Wilson disease, transferrin, which is saturated with iron in hemochromatosis, and ferritin, which is greatly increased in hemochromatosis. All these disorders are called the metabolic or the inherited liver disease. As regards serum albumin, it is commonly decreases in chronic liver diseases because of an increase in the volume distribution, a decrease in hepatic synthesis, or both. Values less than 3 grams per deciliter or hypoalbuminemia suggest decreased synthesis due to advanced cirrhosis, alcohol-related liver disease, chronic inflammation, protein undernutrition. Hypoalbuminemia can also result from the following: excessive loss of albumin, either from the kidney or gut, skin. Because albumin has half-life of about 20 days, serum level take weeks to increase or decrease. Serum immunoglobulins level increase markedly in autoimmune hepatitis. The type of immunoglobulin elevation vary according to the type of the autoimmune hepatitis. For example, the anti-nuclear antibodies and the anti-smooth muscle antibodies increased in type 1 autoimmune hepatitis. The anti-liver kidney microsomal antibody increased in type 2 autoimmune hepatitis. The immunoglobulin M increased in primary biliary cholangitis. The immunoglobulin A increased in alcoholic liver disease. The primary biliary cirrhosis in primary biliary cirrhosis, the anti-mitochondrial antibodies is elevated. The anti-neutrophil cytoplasmic antibodies is elevated in sclerosing cholangitis. The fourth group of tests is the viral markers. Hepatitis A virus immunoglobulin M, hepatitis B S antigen, and hepatitis B virus anticore IgM help identify the acute infection with hepatitis A virus or hepatitis B virus. The hepatitis B core antigen is a marker of infectious viral material, and it is the most accurate index of the viral replication. This antigen present in the nuclei of the cell. It is not easily detected in the serum. As regards hepatitis C virus antibody, it may remain negative for several weeks or months. Repeat the testing may be necessary. If a strong clinical suspicion exists, obtain hepatitis C viral load testing by using the PCR. Other viral tests include the cytomegalovirus and the herpes simplex virus, immunoglobulin M, and immunoglobulin G. Now we will talk about the interpretation of hepatitis B virus serology using three markers: hepatitis B S antigen, the anti-hepatitis B core total, the anti-hepatitis B S antigen. If the three markers are negative, this indicates the case is susceptible and need vaccination. If the anti-hepatitis B core total and the anti-hepatitis B S antigen are positive, this indicates resolved hepatitis B virus infection. If the anti-hepatitis B S antigen is only positive, this indicates that the patient is vaccinated. If the hepatitis B S antigen and the anti-hepatitis B core total are positive, this indicates active hepatitis B virus infection and usually chronic. In the same case, if the anti-hepatitis B core IgM instead of the total core is present, this indicates acute infection. If the anti-hepatitis B core antibody is positive only, this indicates distant resolved infection, recovery from acute infection, false positive or occult hepatitis B. This figure showed the serologic markers for different phases of acute and chronic hepatitis B virus infection. It may help us to understand the previous table. As we show, the hepatitis B S antigen starts early and it reaches to the peak, then it will decrease, followed by the appearance of the anti-hepatitis B S antigen. In the period between the S antigen and the S antibody is the core antibody, the total core antibody. So if we find the anti-hepatitis B core and anti-hepatitis B S antigen with each other, this indicates the convalescence or the resolvement of infection. But if we find the hepatitis B S antigen with the anti-core total, this indicates the infection. It is usually, as we said, chronic infection. If it is hepatitis B S antigen with the anti-core IgM, it will be acute infection. The fifth group is the tumor marker alpha-fetoprotein. It is a glycoprotein that normally synthesized by the yolk sac in the embryo and then by the fetal liver. It decreases rapidly during the first year of life, reaching adult values by the age of 1 year. An increase in the alpha-fetoprotein should prompt consideration of primary hepatocellular carcinoma. Serum alpha-fetoprotein generally correlate with the tumor size, the differentiation state, and the metastatic involvement. Because the small tumors may produce low levels of alpha-fetoprotein, increasing values suggest the presence of HCC, especially when the tumors are more than 3 cm in diameter. So the alpha-fetoprotein help to predict the prognosis. Not all the HCC produce alpha-fetoprotein, thus it is not an ideal screening test, but it may be used to monitor the response to treatment. Mild alpha-fetoprotein elevation also occur in acute and chronic hepatitis, so it is not a specific tumor marker for liver cancer. Finally, we must know the sample for liver function tests. The preferred sample is fasting serum sample. It is preferred because lipemia will increase the bilirubin concentration. Alkaline phosphatase shows higher values following the ingestion of high-fat meal. Also, we must avoid hemolyzed sample because it may decrease the reaction of bilirubin with the diazole agent, results in false low bilirubin result. Also, dramatically increase the serum AST and cause a slight elevation of alkaline phosphatase. Alkaline phosphatase activity increase on standing. As regard prothrombin time, the preferred sample is plasma. We use sodium citrate as anticoagulant in a blue top tube. If the specimen analysis will be delayed after 24 hours, remove the plasma and freeze the sample. Rejection criteria for prothrombin time: clotted sample, overfilled or underfilled tubes, hematocrit over than 55% requires rejection. Thank you for your listening and hope to know your feedback about the lecture, and goodbye.